Hey everyone, welcome back. This is part 3 of 3 of Conditions 1, Medical Issues of Infants and Young Children. All right, next up is congenital spinal conditions. So congenital meaning present at birth, and we're going to look at a couple different spinal conditions. The first is Spina Bifida, which is also referred to in one of its forms as Myelomeningocele. So this is a neural tube defect, and the neural tube is the precursor of the spinal cord and coverings. It can cause both physical and intellectual deficits. It depends greatly on the size and location of the opening in the spine and how much of the spinal cord and the surrounding nerves are involved. Taking folic acid, which is a B vitamin, during pregnancy can help prevent spina bifida. We often see with spina bifida increased intracranial pressure. There may be something called an Arnold-Chiari malformation, where the flow of cerebral spinal fluid to the ventricles is restricted or blocked. There may be a malformation of the brainstem and compression on the cranial nerves, which coordinate swallowing. It may require a shunt, and you saw that a little bit earlier, to allow drainage of the cerebral spinal fluid from the ventricles to the digestive area. Children can exhibit learning disabilities or visual perceptual deficits, and there's a range of orthopedic issues with some lower leg and foot malformations, bowel and bladder control problems requiring OT services, and sometimes individuals with spina bifida will require catheterization, self-catheterization for urinating. So it's a wide range, and here's a look at it. It's a very wide range of signs and symptoms depending on the level of the lesion and also how much of the spine is involved. So there's 3 common types. There's more, but there's 3 really common ones. Myelomeningocele, and you can look at the presenter notes to get notes on this. When people talk about spina bifida, this is typically what they're referring to. It's the most serious, and it is when a sac of fluid actually is protruding from the base of the baby's spine through an opening, and that needs to be surgically corrected. This type of spina bifida causes moderate to severe disabilities and can affect urination and as I said, and requires self-catheterization, also loss of feeling in the legs and feet, or paralysis of the legs. Meningocele is the step down, and this is another type of spina bifida. The sac comes through the baby's spine, so there is an opening in the back, but the spinal cord is not inside that sac. So as you can imagine, there would be much less nerve damage. This type of spina bifida can cause minor disabilities. And then the final type that we're going to see is spina bifida occulta. And the occulta is the mildest type. It's sometimes called hidden spina bifida. There's a gap in the spine, but no opening, no sac on the back. The spinal cord and the nerves are usually normal, and many times it's not discovered until late childhood or adulthood. It does not cause any disabilities. So that's spina bifida. Next up is spinal muscular atrophy, and it is a genetic disorder that's characterized by weakness and wasting, in other words, atrophy, in muscles used for movement, so the skeletal muscles. It's caused by a loss of specialized nerve cells called motor neurons that control muscles and movement. There's 4 classic types, SMA 1, 2, 3, and 4, and you see SMA 1 is Werdning Hoffman, and 3 is Kugelberg Welander. And they, they're associated with different types of issues. So SMA1, the child is very weak at birth and has respiratory problems. Life expectancy is only 2 to 3 years, so this can be fatal. SMA2 has near normal development for about 4 to 6 months, then respiratory problems, and the life expectancy is later childhood or adolescence, sometimes to adulthood. SMA3, less severe issues, and children grow into adulthood, but then they see respiratory issues. And SMA4 is the least severe, and there's no change in life expectancy for most individuals with it. We are going to now change tacks, and we're going to talk about a range of congenital abnormalities and deformities. This will be the longest part of the 3-part series, but it's also the last one, and I have a lot of pictures for you to illustrate what's up. All right, so we're going to talk about 4 main deformities and abnormalities listed here, and I'll jump right into it. The first is an orthopedic issue called Marfan syndrome. So it is an inherited disorder that affects connective tissues, or the fibers that support and anchor the organs and other structures in the body. Marfan syndrome is typically noted for people with very long fingers and feet and arms and legs, and it also can affect the heart, eyes, blood vessels, and skeleton. So you see an illustration of a person with Marfan syndrome and how some of the orthopedic issues come out. Next up is Chondrodystrophia and Achondroplasia. So Achondroplasia is the most common form of skeletal dysplasia, one in about 40,000 births, and it impairs the growth of bones in the limbs and causes abnormal growth of the spine and skull. So you can see some pictures of this. And chondrodystrophy is a general term that refers to a disorder that interferes with the body's normal development of cartilage. So achondroplasia is the bone growth, and chondrodystrophy or chondrodystrophia is cartilage growth. Both of them lead to abnormal skeletal growth and formation. So pretty intense issues. Next up is Osteogenesis imperfecta, often abbreviated OI. This is another genetic bone disorder that's present at birth, and it is also known as brittle bone disease. A child born with OI may have soft bones that fracture easily, bones that are not formed normally, and other problems. Signs and symptoms can range from mild to severe. In severe cases, the child with OI fractures many bones during the course of normal life. So it's not like they're playing hockey and they break their leg. Simple movement and impact can cause trauma to the skeletal system because the bones are so fragile and brittle. So another prep for class thought question: what safety precautions might you need to take when treating a child with osteogenesis imperfecta? Consider ADLs for an infant. So what's up with that? What might you want to do to help protect their bones? And also play for a preschooler. Another slide that just continues our discussion of orthopedic issues. And this one is Arthrogryposis Multiplex Congenita, or AMC. Now, this is a disorder that involves the development of multiple joint contractures, and it must involve 2 or more areas of the body prior to birth. So the child is developing contractures in utero. A contracture occurs when a joint becomes permanently fixed or bent, permanently fixed in either a bent or a straightened position, and it can impact the function and range of motion of the joint. So this slide, if you dig in, will show you some of the different places on the body where these contractures occur, and I'd like you to consider what the functional deficits might be from AMC. Here are some photos of AMC, and it just gives you another look at it. So you can see that there's a range of contractures. They can happen in the jaw, they can happen in the limbs, the hands and feet, etc. Now we're going to talk at a high level about congenital deformities and abnormalities. So there are a wide range of these congenital limb deficiencies, which either means that a piece of the limb is missing or that a portion it is connected to another, well, a piece of the, let me start over. Okay, so an entire part of the body is missing, or it might be connected like a hand to an upper arm. So there's pictures for you here. Amelia, as you can see in the drawing on the left, is missing a part of the body entirely, missing an arm, missing a lower leg. A paraxial defect extends transversely across the entire width of the limb. So it's a partial missing limb. Central, the entire central portion of the limb is absent with foreshortening. So you can see in the third drawing that the hand is attached to the upper arm, or the foot is attached at the thigh. And finally, another type of paraxial where there's a segmental absence of preaxial or postaxial limb segments. And you don't need to know all of these names. If you're working with children with orthopedic issues, definitely, or if you're interested in that, you'll want to learn it. But what I do want you to know is that there is a range of disabilities and a range of these disorders. Here's some examples of what we might see and what OT might be very involved in treating. Polydactyly, which is an extra digit on the hand or foot, and this is typically surgically removed. And then syndactyly, which is a webbing of the tissue between the digits on the hand or foot, typically surgically corrected. And OT has a role both pre and post surgery for both of these conditions. I would like you to know both of these terms. Here are some photos of radial and transverse deficiencies. And you can refer back to these in the slide deck as you'd like. Next up, we're going to look at Sprengel's deformity, another orthopedic issue. This is an abnormally elevated scapula that's held in that position by a ligamentous band. Surgical correction releases that band, but you can see in the picture on the left that the left scapula is much, much higher than the right. And as you also know, the scapula, is this lever of movement, and so having scapulas that are uneven will impact one's movement. Brachial plexus injuries are next. And we do see a fair amount of brachial plexus injuries in children that we treat. They are typically unilateral, in other words, on one side, and there's two main types that I'd like you to be familiar with. The first is Erb's palsy, and this results in problems at the shoulder and the elbow, and Klumpke's palsy, which is problems with the intrinsic muscles in the hand. Erb's palsy is typically associated with nerve roots from C5 and 6, in other words, up higher on the neck, which makes sense with the shoulder and elbow. And Klumpke's is nerve roots from C8 to T1. Here is the brachial plexus, just for your reference. You've probably seen it before, but you can see where C6, 5, 6, and C8 to T1 come out, and those are the parts of the brachial plexus that are impacted. Either they get stretched, they get compressed, or they get injured, and this often happens as the baby is moving through the birth canal. Some pictures that don't really show it great, but there you go. All right, and last but not least, are autoimmune conditions. Again, there's a range of these. I'm just going to bring your attention to two. The first is juvenile idiopathic arthritis, or abbreviated JIA, and the other is PANS or PANDAS. So looking first at JIA, the onset of it is from 6 weeks to 16 years of age, and it is characterized by pain and swelling in the joints. There are 5 main types, and interestingly, this may or may not resolve over time. So in your presenter notes, you have the 5 types. Systemic onset JIA affects 1 or more joints. There's often a fever and a skin rash. Some inflammation of internal organs is possible, including heart, liver, spleen, and lymph nodes. It's least common. It affects about 1 in 10 or 1 in 7 children with JIA. Oakley articular JIA affects 1 to 4 joints in the first 6 months of the disease, and then if no more joints are affected, it's called persistent. Polyarticular affects 5 or more joints, so you can see that the types are very much mediated or labeled by how many joints are impacted and how severely. Enthesitis-related JIA, the child has arthritis as well as enthesitis, and this is a swelling of the tissue where the bone meets a tendon or ligament. So it often affects the hips, the knees, and the feet. And finally, psoriatic arthritis. So the child may have both arthritis and psoriasis, which is a skin disease that produces red and scaly skin over various parts of the body. Your last prep for class, what safety precautions might you need to take when treating a child with JIA? And how would JIA affect fine motor intervention for a 10-year-old? So again, I haven't given you a ton of information, but this is for you to think about and to imagine, what might I need to consider? And finally, we'll talk about PANS and PANDAS, and they are they're abbreviations for some pretty long terms. PANDAS is pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. So it's an autoimmune disorder. It's induced by an infection, in this case strep. It disrupts neurological function, and the reason that we want to know about it is that it can often be misdiagnosed. The hallmark for PANDAS is a sudden, acute, and debilitating onset of intense anxiety and mood lability, and it's accompanied by obsessive-compulsive or OCD-like issues or tics, and it's in conjunction with a streptococcal infection. So we want to be on the lookout for that if we see kids who have a real sudden change in anxiety level or mood lability, in other words, changeability of moods. In some instances, the onset will be 4 to 6 months after a strep infection because the antibiotics that were given, like for strep throat, did not fully eradicate the bacteria. All right, congratulations on completing Pediatric Conditions Part 1. You've gone through 3 parts, but the first lecture. We have 2 more lectures on different topics that affect children, and we'll get to those in the next couple of weeks. Thanks so much for your attention. Have a great day. Bring your questions to class or email me, and I'll be happy to address them. Thank you, everyone. Take care. See you next time.